Welcome, everyone. It's great to have you here with us. I'm here today with Dr. Jeff Pollard, who is a longtime friend and dear colleague of mine. Dear friend is actually where I really want to put the emphasis. Jeff and I have worked together for decades in the field of threat assessment on some fascinating and dangerous situations, and have done a ton of work together to really help get the word of threat assessment out. Jeff is a retired board-certified clinical psychologist and a police psychologist. He's also a master trainer in threat assessment, certified master trainer in threat assessment. He was co-founder of the campus threat assessment team at the university where he still teaches, and he is now adjunct faculty in the criminology department teaching threat assessment. So, Jeff, first of all, welcome. I'm delighted that you're here today.
I think we started this when you were a teenager, right?
I think we did too. It has to be. Like how can we possibly have accomplished so much? You especially in this short period of time. Yes. Threat assessment prodigies really is what the name of this this channel should be.
Well, it's a real pleasure to be here. I'm honored to be here. Always, really honored to be able to work with you. You're just a spotlight in this whole field, and it's great to work with you.
And child prodigy. I think we've
Yes.
established threat assessment child prodigy.
I think that's necessary to make sure we know.
So I want to talk about an issue that you and I have talked about over the years, but is often not discussed in threat assessment, and that is provider safety. Safety of clinical psychologists, licensed mental health workers, social workers who are doing the work of really oftentimes a lot of the intervention work. We often don't talk about the risk that sometimes providers are under themselves. So let's start with kind of getting a baseline. Tell me more about how often this happens.
Well, I guess there have been, we can count maybe 10 studies that have been done in this since the early 80s. We've seen a bit of an uptick as these studies report, and right now it's around 40 to 60% in terms of what the range looks like of clinicians that experience some form of violence, 10 to 40% reporting physical assaults. Most incidents involve verbal threats or intimidation, but serious assaults and weapon threats are part of that as well. Stalking, about 1 in 10 clinicians. Men more likely to be assaulted than women, but women more likely to be stalked than men. So it's roughly 1 in 4 psychiatrists have been subjected to this as well. Consequences involve psychological stress, people becoming hypervigilant, lasting practice changes, people walking away from their practice, lack of safety protocols, lack of training, inconsistent violence management training really has contributed to it. And also there's a very unfortunate notion within the field that if this happens to you, that it's a reflection on your clinical prowess. And that's one of the saddest things about it, is that people are reluctant to report it. And we see that in these anonymous reporting surveys that we've administered.
So it almost sounds like there's a stigma of even reporting or sort of admitting that you have any sort of problem, that because it could be seen as or providers may think it's a reflection on the care that they're providing.
Certainly those who have experienced it say that about why they didn't report it. Others will say, no, I can understand how that could happen, but many people will say, I didn't report it because I was afraid that I would be seen, as being somehow incompetent.
Is there a case example you can share? I want to dig into some of these statistics, but is there a case example that we can share that you can describe without naming names and all that?
Sure. So I'll tell you about one I'm pretty familiar with, that in which a former client patient followed the vehicle of an individual who he believed to be his provider. The car pulled up to an elementary school, and there the partner of the provider got out to pick up their child. The former client got out of the car and murdered him on the spot in front of the child. And that's probably as graphic an example I can give you, but I can give you chapter and verse of other kinds of situations, people who have been stalked for years by their former clients, people who've had all kinds of intrusion, drive by their house continually, all the things that you think about typically happening within a stalking situation happen to providers, and it can be devastating, absolutely devastating.
Well, but it's happening to providers from patients or former patients, correct? I mean,
Current and former, yes, absolutely. People that they know because they treated them professionally.
so in the example you shared, do you know why the patient or former patient was stalking the provider in the first place, or the car that they thought the provider was driving?
This is an example of one of the risk factors that we see in these cases that have to do with not with the clinician themselves, but the circumstances, situational risk factors. And this particular case, the provider wanted to transfer this particular client to another provider because we are required by our ethics, and when we don't feel that we're making progress, not to terminate, but rather to try and get better treatment, or treatment
Oh,
seems more appropriate. Yes, the APA guides psychologists, but all of the licensures and all the professional providers have this basic requirement ethically, is that we not just terminate someone we're not doing well with it, rather that we find someone or find a recommendation that would be better for them, or at least an attempt to be better. And that's what happened in this case. And the person reacted very, very strongly. The boundaries between providers and their clients, termination, discussions around hospitalization, negative feedback about substance use can be another triggering point. And then there are physical kinds of risk factors like office isolation. This is why you never want to see somebody in an office where you're the only one there if you can avoid it. And lack of on-site security or panic procedures is another one, where you don't have a resource where you can get help when you need it. And people are not necessarily great at being able to predict that they might need it, even though there are
yeah.
pre-incident indicators. As you and I well know, violence doesn't occur in a vacuum.
I want to get to those indicators in a minute, but it strikes me that some of what we may, so first of all, the dynamic you were talking about, in some ways, to me, it made me wonder if there's a similarity to what we see with the development of domestic abuse, that you don't necessarily see that a person who ends up becoming abusive in a domestic relationship doesn't necessarily start out that way. And so so you're in a close relationship in a way, and that things can become abusive, and they may be harder to see when you're in a close relationship than someone from the outside saying, hey, this dynamic now, this person shouldn't be showing up at your grocery store. They shouldn't be following you home, things like that. Am I off base there? Is there similarity?
Yes and no.
Okay.
Um, when you look at folks who are domestically violent, you usually see someone who at least believes that a solution to a problem can be violence.
Mm,
And those who don't believe that don't usually become violent unless they're put in a position where they're having to defend themselves or someone they love.
yeah.
But people who become violent in relationships usually at some level believe that violence is a good solution. You're seeing different kinds of predictors for patient characteristics in these circumstances. Things like History of violence, of course, just like in domestic violence, yes. But personality disorders, just like the existence of a personality disorder, is a risk factor. Active psychosis can put someone at risk. Being intoxicated in the moment, in the clinical moment, non-adherence to treatment or termination conflicts, those kinds of things. Comorbidity, of course, with substance abuse, just like we see in threat assessment, is also a risk.
Comorbidity meaning things that are occurring at the same time. You have a mental health diagnosis and a substance diagnosis, correct?
Correct. Absolutely. Yeah.
You and I have talked a bit about, I know you provide training to counseling center staff, for example, on practices to help enhance their safety. What recommendations do you give? What strategies do you suggest?
The number one thing I recommend, this is for all clinical challenges, but the number one thing I recommend to prevent violence within the clinical setting is ongoing, regular, normed consultation with one another. You
What do
need
you
to
mean?
have people that you can talk to about the cases that you're seeing, and you need to think a little bit about what the risk factors are. So if you see someone who has a personality disorder and they're using substances and they're not talking to you, they're avoiding, for instance, the recommendations you're making in terms of additional, like maybe going to meetings or maybe having some kind of adjunct treatment for the actual substance abuse. If they're resistant to that and you're not talking to someone about it, that's a huge risk factor. So that's the number one thing that I recommend that people talk about.
Is regularly consulting with other therapists about your caseload. Is that what you're saying?
Number one,
Okay.
absolutely. Team-based care and visible colleagues is a kind of another way of saying that. I would love to have people have formal threat assessment or reporting procedures. This is something else that clinicians don't understand. If someone threatens you in the clinical moment, you should report it. That's a violation of law. And people feel like, oh, well, I'd be fracturing the therapeutic relationship if I did that. Possibly you would be, but you also might be possibly saving your life, the lives of your colleagues, maybe your family, other people. So it's extraordinarily important to get help if you're being stalked or you're being threatened. Someone's coming around to is doing those kinds of things. You also need training in de-escalation. And in-depth training, not just, oh, speak slowly, lower your voice, that stuff, okay, but that's what you teach, anyone. You need better, more clinically oriented, de-escalation processes than just that. And, I would also take a look, I'd walk around, and I've done this in counseling centers. I've walked around, I've designed counseling centers, frankly.
Really?
The one where I'm working now, where I designed that one when I was director of the counseling center there. Do people have more than one way to get out?
Oh, right.
Have more than one exit? Windows count, but if you're on the third floor, they don't. So more than one way to get out of a building is a really, really good idea. And look at the way the layout is, and do you have alarms, and do you have help buttons? We try not to call them panic buttons. We call them
Right.
alarms. We need that needs to be there for provider safety.
Getting back to the example that you shared, I I I don't know if you can say from that example, but in a situation where s- you've got a patient you need to transfer to a different provider, things aren't working, or whatever, for whatever reason you want to transfer them to a different provider. Are there ways to do that help to minimize risk? Obviously not negate it completely, but to help to minimize risk.
I think the first thing you do is start the discussion with the client by saying, how do you feel we're doing? Do you think we're making progress? When you look back on what we've done together over the last 6, 12 months, What have you seen? What do you see that's been valuable for you? What difference has it made in your life? What things do you wish we had done better? What things do you think could be better? So you engage them in the notion of evaluating how well the counseling process is working. I think that's a critical step, because if you're going to say to them, I agree with you, and I'm concerned that we're not making enough progress. I don't, I have a responsibility to you to make sure that you're improving, that things are getting better for you. I want to make sure that's happening. So you try and engage the person the very, very best you can. And while you're doing that, measure how much pushback are you getting? Are they suggesting, um, I need to see you, doc. I mean, I have to continue to
Right.
see
It has to
you.
be
I don't know
you.
if I could see anybody else. That bothers me.
Yep.
And I would be talking to somebody immediately upon, not in the moment. I would say, well, I understand. I would be very accepting of that, and tell them that you understood, not reinforcing, but accepting. And then go and talk to somebody who knows a little bit about threat assessment, maybe a lot about threat assessment, and begin to talk about what risk factors might there be in the relationship already.
So interesting that you raised kind of the talking to someone about threat assessment piece, because I think a lot of people may mistakenly think that part of standard training for mental health providers is behavioral threat assessment, but that's not the case, right?
No, it's not.
And
There are programs that emphasize assessing violence potential, and almost every program will touch on it, but in depth, no, not generally.
yeah.
There are programs that do it in depth. I can think of about 5 of them that do strong in-depth violence risk assessment training. But for the most part, there it's in some ways not as much depth in which you and I have gone today.
Yeah. It's such a shame because we see this among mental health providers. We see it among local law enforcement too. Oftentimes, federal law enforcement and even state law enforcement will get training in threat assessment investigations, behavioral threat assessment, protective intelligence investigations, whatever they call it, a preventative investigation designed to help mitigate risk of violence.
Mhm.
But local law enforcement often doesn't, and these are where the threats are often reported. So anyway, sort of my magic wand. If I could wave a magic wand tomorrow, and I didn't realize that mental health providers get as little as they get. But I would also think that the problem of provider safety is compounded by the fact that even if you have good training in threat assessment, if you are the one who has been threatened, it's particularly difficult to be able to do a thorough assessment there, especially when you, as a provider, may be invested in continuing that care and feel like, if we can just do a little more work together, I'll be able to do a successful intervention here and get that person away from stalking behavior, fixation, whatever the case may be.
Providers are so strongly motivated by wanting to help that it can, in some instances, I'm not saying regularly, but it can, in some instances, blind them to what's going on in terms of a building concern about the response that a client might have. It can be. I've had multiple consults with providers who said, I don't know what's going on here. And as we talk through it a little bit, it's become clear that there's more going on than meets the eye in the moment, in the therapeutic environment. Look, it is very, very true, and providers know this, that clients will come in and often try and be on their best behavior
Yep. We know
because
this
they
from threat assessment. We talk about this
absolutely
all the time. Oftentimes, a provider has less information than a threat
yes.
assessment team might have about a case.
Clients want the approval of their provider, and when they don't get it, then they're at more risk. So if I'm telling you you're not doing as well as you think you are, or I need for you to see someone who has more expertise in this area than I do, that sounds like a rejection.
Yeah.
And for people who are sensitive, they have that ego wound. It becomes, it can snowball. They can be thinking about it when they're trying to go to sleep.
I need to pause here for one quick sec, and then we'll resume. So hang on.
Okay.
Jeff, let me circle back to the statistics you talked about earlier,
Sure.
because I find them astounding and disturbing. We hear a fair amount about risk to nurses, for example, in hospital settings, risk of violence from patients, from family members, et cetera. I don't think I was aware at the prevalence of risk and threats and violence that you are talking about that providers face. I I'm really surprised. I knew it happened, but I'm surprised at how often in terms of the statistics you were quoting.
People are not surprised to hear about the amount of violence that providers are at risk for in inpatient settings. They understand that
Right.
there are many folks who are in inpatient settings are extremely agitated. And there are chemical restraints that are used, of course, and
Right.
and that kind of thing happens. But most people don't understand that people in outpatient settings are at risk as well. If you the first study that I really look at is the Bernstein study from 1981, in which 14% of the respondents reported being physically assaulted, and 35% said that they were physically threatened. And this was the very first study that I put some weight into that showed that outpatient providers were at risk. You can go forward. There's many of these. Psychiatric residents have a 5 to 48% lifetime risk of across all studies. That was a group study of being subjected to this stuff. 2023, they looked at counselors in 12 states. 51% of them experienced client initiative violence. 79% experienced verbal or physical violence combined. So it just keeps going up. There's a
Wow.
more recent study, 2022, a systematic review, lifetime prevalence. Again, over 13% in victims, mostly women in that one.
Right.
They looked at female providers. And then you see, again, psychiatrists, not surprisingly, are at most risk. But it's,
Why is that? Why do you say not surprisingly? I'm curious.
well, in our field, when severity is when you look at severity, psychiatry is generally thought of as the place, sort of then this is unfortunate because it's not true. So many of them are such terrific providers, but the severity goes to the psychiatrists. They're the ones that
Got it.
usually will take on some of the most difficult cases. And of course, they have more tools
Got it.
because I think it's 5, maybe 6 states psychologists can prescribe, but in most states they cannot. And
Right.
psychiatrists, of course, can prescribe in all states.
Okay. Oh, that makes sense now. Now I
Yeah.
understand that.
And then this goes across um, types of providers as well. We see these kinds of research, counselors in general, that's very common. We see 80% of them subjected to any kind of violence, including verbal violence. 10 to 20,
80%.
yeah, 10 to 20% of them. This is a study this is a collection of studies. Bride and Kempf in 23 found that 80% had been subjected to um, verbal violence, well, 20% physical violence. Ringstad in 25 found 60 to 70% of social workers, um, verbal or threats, 10 to 15% physical violence. So it's a common across all. One of the only kind of variables around this is that in any of the, shall I say, specialties, in any of the professions that provide mental health services,
Mhm.
what you'll see is the folks who have less experience are a little more likely to experience physical violence.
Less experience as a provider
Yeah,
puts them at greater risk.
that's right.
How, like, Any understanding as to why, or any guesses on your end as to why that is? They don't know what to look for, no, not to handle. Like, I'm curious as to what you think's going
I
on.
think it's just experience. I think it's just experience and a development of of the what has commonly been called the third eye, which is the ability to see beyond the moment with
Yeah.
a client.
Are you seeing anything, any improvement in sort of the next generation of providers coming up? Has anything changed, been added to kind of standard, you know, graduate programs, for example, for providers around awareness, anything like that, that's getting better?
Yes, absolutely. Programs are aware. They look at this data as do we. They know that this is a problem. One of the problems is, of course, is that in order to obtain a license, in most states, there is a prescription in terms of the amount of what you need to study.
Oh,
And
oh, okay,
yeah,
got it.
and so this topic is not considered an in-depth topic in most places because there's so many other things that are looked at. There's just
Okay.
a lot that gets squeezed into a very short amount of time.
Yeah.
But yes, there is improvement, and more providers are being made aware, and more providers are able to articulate that there is danger in their patients, and that they're more aware of what's going on. They're better at being able to spot the client that may become problematic. That is true.
So I keep coming back to something you said earlier around one of the recommendations, or sort of your number one recommendation, is to have regular consults with other providers on your caseload generally. So not just when you have a concerning case. Like, here's what I've got, almost like creating a like a rounds that you might do in an inpatient setting, or a hospital setting, around kind of like, hey, here's what we're seeing, this is what we're doing. Because I feel like that part of what you and I have learned as threat assessors and been trained in is relying on a team, and that providers often don't get that benefit because it is oftentimes a one-on-one engagement between a provider and a patient.
It's ironic because so much of healthcare, doesn't matter where you look at it, so much of healthcare is considered to be a group activity. No matter what you're looking at, no matter what the diagnosis is, you're looking at teams. You
Yeah.
know, very little of it occurs. All training, for instance, occurs in teams.
Yeah.
Almost all, unless you're doing, one-on-one psychotherapy with your supervisor, and you're looking at tapes and you're talking about the process and the content of what's going on. But for the most part, it does. But in practice, when things happen, it too much isolation happens. Now, I'm from a university college counseling center background. Spent many years there as a counseling center director and as a staff clinician. And there you have a natural camaraderie among staff.
Interesting.
But even there, and as a matter of fact, we're just about to do a study when we're going to look at that particular group. Um, Even there, though, there's isolation. People don't share when they feel like they might put themselves at risk sometimes, and for self-perceived criticism. Um, and And it's a shame when that happens. Sometimes things get a little further down the road than they need
Mm.
to before someone will share. Other folks are just absolutely very good at it, and I think it creates actually a better learning experience for everyone, and certainly it creates a safer environment.
Jeff, as always, love talking with you, and I learned from you. And I don't know if you can hear the squeaking of the puppy in the background, but
I can't, but I wished I could. I think I should.
I've had to turn the volume up to be able to hear you on a couple of occasions. So I hope this is the first of many conversations I get to have with you around different aspects of threat assessment. You and I have worked together for so long, again, starting when we were very young, but we've worked together for so long in this field, not only in higher ed, but in K-12 and corporate clients, high profile, celebrity clients, et cetera. And it's such gratifying work to get to do this work alongside you. So thank you for joining me for this discussion today, and I look forward to many more.
Right back at you, Dr. Randazzo, and I'm happy to help anytime.
Thank you. All right. That's it for us today, folks. Don't forget to like and subscribe. See you soon. Take care.